It now gives me great pleasure to introduce Professor Alan Bryer. Professor Bryer and I go back a long way. We trained together as registrars in internal medicine, and he went into neurology and I went into nephrology, and he had an outstanding career in neurology, but developed this major interest in stroke and stroke care. And he's been one of the pioneers of developing acute stroke care in South Africa. He's president of the Stroke Society and has widely published in this area. And it gives me great pleasure to now ask him to present his talk, Thrombolysis and Device Therapy for Acute Stroke, Pushing the Limits.
Thank you, Brian. Thank you, ladies and gentlemen, and for inviting me to speak at this forum. Now, my disclosure form is on page 48 of the program. Now, many in this audience will remember a time, because it's not such a long time ago, that stroke was considered the Cinderella of non-communicable diseases. Because when her sister, myocardial infarction, came into the emergency unit, she got preferential treatment, everyone responded rapidly, and got special care. If Cinderella stroke arrived at the same time or later, she got shoved into a quiet corner, was allowed to aspirate, dehydrate, and lose 2 million brain cells per minute in the evolving infarct area. Now, fortunately, times have changed, never mind not changing, and there has been enormous progress in the management of acute ischemic stroke. There has been a quantum leap in the progress regarding the management. And in my opinion, there have been, in fact, 4 quantum leaps in stroke management. The first quantum leap was the seminal work that was done in Glasgow by Peter Langhorne and duplicated elsewhere in the world, showing that if a patient was managed in a dedicated stroke unit, governed by protocol standard operating procedures, by a multidisciplinary team trained in stroke care, then the outcome was better for the patient than if they were treated in the general medical ward in terms of less mortality and less morbidity as well, not at the cost of reducing mortality. Well, that was quite a while back. And the next quantum leap was a bit more controversial. We were behind the cardiologists in this field, reperfusion therapy with intravenous thrombolysis. And in some quarters, this is still a controversial topic. Now, at the center of reperfusion therapy is the concept that time is brain. The sooner that you're able to establish reperfusion, the better the chances of a good outcome, much like myocardial infarction. Stroke should be treated as an acute medical emergency, and that message, I think, is beginning to seep through. So what about intravenous thrombolysis? It's been a while since that seminal publication in the New England Journal of Medicine. Well, firstly, it's bedeviled by a definite inherent risk. And I don't think at this point in time it'll be possible to remove that inherent risk. And that inherent risk is symptomatic intracranial hemorrhage. In other words, hemorrhage into the infarct or a distant site, which allows the patient to deteriorate. And some of those patients may in fact die from the symptomatic intracerebral hemorrhage. However, at 3 months, the benefit outweighs the risk if intravenous thrombolysis is given to the appropriate patient with the appropriate indications. Again, time is brain. The earlier that you are able to administer intravenous thrombolysis after symptom onset, the higher the chance you'll see of achieving a better or good outcome. In other words, functional independence. It has indeed become the standard of care in certainly the high-income countries and many of the middle and low-income countries as well. And if a patient is not offered the option, if they're suitable for this type of therapy, of intravenous thrombolysis, they run the risk of litigation. And certainly that's become a problem. Those cases come across my desk, and it's become increasingly frequent. And far more cases have evolved from lack of offering this type of therapy to a patient than from the complication that can occur as a result of this therapy. And I think that's been a worldwide experience. So what about, to look at this controversy, I think one of the best papers to try and get a grip on it is a paper that was published in The Lancet, and it's written by the who's who in the stroke world across the world. And it looks at, in fact, a meta-analysis of individual patient data, so a very high level of information from randomized trials. And this looked at over 6,500 patients in 9 randomized trials. No eligible trials were omitted. And it compared the use of intravenous TPA for the correct indications in acute ischemic stroke versus best medical therapy with placebo or open control. And what they found was that tissue plasminogen activator increased the odds of a good outcome with earlier treatment and was associated with a better proportional benefit. Treatment within 3 hours resulted in a good outcome in 32.9% of cases versus 23% for controls, or an odds ratio of 1.75 in favor of treatment. When you treated the patient from symptom onset 3 to 4.5 hours later, good outcome 35 versus 30% for standard medical treatment. And then after 4.5 hours, you lost the benefit. Treatment benefits were similar irrespective of age. Initially, all the trials were done in people under the age of 80, and then the information became available over the age of 80, so irrespective of age or stroke severity. However, the downside was mortality. Fatal symptomatic intracranial hemorrhage within 7 days, often very soon after the administration of treatment. 2.7%, between 2 and 3% mortality within the first 7 days versus 0.4% for those that did not receive intravenous TPA. However, at 3 months, it evened out. And then at 3 months, there was no statistical difference between mortality, whether you received the intravenous TPA or whether you received standard medical treatment, because stroke itself is a disease associated with a significant mortality. So despite the absolute increased risk of early death as a result of symptomatic intracranial hemorrhage of about 2%, 2 to 3%, by 3 months, this risk was offset by an average absolute increase in disability-free survival of about 10% for patients who were treated within 3 hours, and about 5% for patients treated within 3 to 4.5 hours. Now, the numbers needed to treat when given to the appropriate patient. If you can treat the patient within 90 minutes of symptom onset, the numbers needed to treat to get functional independence is 1 in 4. If you wait and you treat within 3 hours, it drops to 1 in 9. And if you treat at 4.5 hours, it drops to 1 in 14. This is using uncontrasted CT scanning to exclude hemorrhage, and the uncontrasted CT scan, I must tell you, looks normal at this point in time. What you do is exclude hemorrhage, and by and large, the scan is looking normal. If you're seeing changes on the uncontrasted CT scan, then you have to, the experienced stroke physician will have to make a decision whether that's an appropriate patient to give the thrombolysis to or not. There are, like the previous speaker, there are the doubting Thomases, there are the dissidents. They are a small minority, but they are very vocal. There's a group in South Africa, Australia, even in the UK. And when we first published our stroke guideline regarding intravenous thrombolysis, it was no different to any other internationally published stroke guideline. North America, Canada, Australia, the European Union, the Soviet Union, they're all the same in terms of the recommendation. And yet this is what was written to our journal. There is no compelling evidence to support the use of TPA in stroke. Its use beyond 3 hours is dangerous, and it should not form part of a national guideline. Now, I can understand part of the reason for this concern because it comes from the emergency unit doctors. They don't manage stroke in the long term. And I think for them, the very idea that they can give a medication to treat a condition which could potentially result in the death of that patient in the emergency unit fills them with some great degree of concern. But nevertheless, if you look at the overall data, there is net benefit in those patients, even given the small risk of a symptomatic intracranial risk and the risk of mortality as a result of that. Each country had their own regulations concerning TPA before it was licensed for use for ischemic stroke. The European Union had this vast SITS-MOST register where every time it was used in clinical practice in any center, not within the context of a trial, it was registered in Sweden, and eventually the data of this massive registry looked exactly the same as the clinical trials. In the UK, again, they weren't entirely happy alone with the European Union's recommendations. They had their own working committee led by Sir Ian Weller with a panel of 18 members, and they sat and looked at all the data very thoroughly, and again came up with the same conclusion. The benefit, the risk of alteplase treatment of acute ischemic stroke is positive when used within the terms of the license up to 4.5 hours after symptom onset. Benefit is highly time dependent, and minimizing time to onset of treatment is critical, ensuring the best outcome. However, thrombolysis for acute ischemic stroke should not be an ad hoc affair. It shouldn't be done on the basis of a snap decision when the clinical problem presents itself for the first time. The physician must have some experience, know what they're doing, and it's protocol driven. There are indications and contraindications for this type of therapy, and the patient should be made aware of what the risks are as opposed to the potential benefits. It is protocol driven. Well, the next quantum leap is in fact an extension of the previous quantum leap, and that is fairly new. The use of endovascular therapy. We are behind the cardiologist in terms of this, but for good reason. It has certain advantages, clearly. A higher recanalization rate. The best you can achieve with intravenous TPA recanalization rate is between 30 and 45%, and it tends to be for more distal occlusions. With mechanical thrombectomy, between 70 and 80% and more recanalization rates can be achieved. But there are distinct disadvantages. The delay in initiation of treatment, you've got to get the cath lab ready, the endovascular person has to be mobilized, come in, open up the laboratory. There may be difficulties getting the catheter to the site of occlusion. There may be damage to the arterial wall, fragmentation and distal embolization to new territories, and again there's a risk of symptomatic intracranial hemorrhage. But the figures from the more recent trials are quite staggering in favor of mechanical thrombectomy. So I'm not going to go into all the different trials, but I'm going to try and summarize the effects of these trials. Mr. Clean, ESCAPE, Extend IA, Swift Prime, and Revastat, all published within the last 2 years. So looking at a total of about 1,200 patients, all these patients had high clot burdens. So the clot was in the terminal internal carotid or the proximal segment of the middle cerebral artery. When you have a higher clot burden, you can imagine giving intravenous TPA through the arm, it circulates through the whole body and is less likely to dissolve a large clot in a proximal cerebral vessel. They excluded large core lesions in 4 out of these 5 trials. Mr. Clean was fairly open in terms of the criteria, but they used other techniques. The aspect score, which I won't get into, but it's quite a tricky thing to actually calculate the aspect score. It depends on the quality of the image. Then there's advanced imaging with rapid, which I'll go into, and the aspect score and using MRI. What is worthwhile remembering is that in these 5 trials, this is critical, the vast majority of those patients had bridging treatment. They first received intravenous TPA, and then they went on to the cath lab, and they had mechanical thrombectomy. So between 68 and 100% across these trials had bridging therapy with intravenous TPA. And then, even though, according to the criteria of these trials, they had a longer period from symptom onset, the vast majority were treated with endovascular therapy from within 6 hours of onset of treatment. So therefore, in routine practice, at that point in time, one could only recommend this type of treatment within 6 hours of onset of treatment. And that was a pretty important point. However, if you looked at the absolute risk reduction in these patients, the median absolute, not relative, but absolute risk reduction was 24%, ranging between 13 and 43%. So the numbers needed to treat to get this kind of result, functional independence from a severe stroke, not a minor stroke. These are proximal occlusions with a high stroke score. 1 in 4 to get a good outcome, in other words, functional independence. Very high recanalization rates and symptomatic intracranial hemorrhage 0 to 8%, which pales into insignificance given that these are large strokes, and look at the net benefit. And then mortality was similar or equivalent or even less than the controls who did not receive an endovascular procedure. So then followed a systematic review looking at a meta-analysis of all these randomized controlled trials, even some of the prior ones that were less successful for a number of different reasons. Over 400 publications, 8 studies, and again the results indicated that with mechanical thrombectomy, improved functional outcomes, in other words, a modified Rankin score of less than 2, which means they're functionally independent, the odds ratio of 1.56, a tendency towards a decreased mortality, improved outcomes, and symptomatic intracranial hemorrhage was not increased, because these are big strokes compared to the best medical treatment alone. The odds ratio in favor for functional outcome increased by more than twofold, with newer generation thrombectomy devices were used in more than 50% of cases in each trial. So substantial improvement. So conclusions, there's now clear, unequivocal clear evidence for improvement in functional independence with endovascular thrombectomy, mechanical thrombectomy, compared to standard medical care. Endovascular mechanical thrombectomy should be considered as a standard effective treatment alongside thrombolysis in the eligible patients. Well, these are fairly new results. Can they be duplicated in clinical practice? We are nowhere near getting our clinical practice and pathways ready for all these new therapies. What is required is appropriately trained interventionists who are doing frequent procedures. In these clinical trials, one of the stipulations were not only were they well trained, but they were high volume centers. The interventionist had to be doing high volumes of intracranial work, thrombectomies. It's got to be done in stroke units with a capacity and required skill set for endovascular therapy. Now, the intracerebral vessels are not the same as the systemic vessels. There is no muscle to support these vessels. There is a very thin adventitia. There are fewer elastin fibers in the media. And the risk is that you can still perforate the vessel, distal embolization, that do not exist in the coronary vasculature. So brain tourism on the way to the heart should be discouraged. One should keep a log. I know I'm talking to cardiologists, I'm probably the only neurologist in the audience, but this requires additional and specific training to be able to navigate the intracerebral circulation and to deal with blood vessels that are different and subject to different anatomical variations as well. It's critical, I think, to keep a log of one's results at a comprehensive stroke unit which is able to offer this. So what is the fourth quantum leap in terms of stroke management? Well, the fourth quantum leap is another game changer, because the fourth quantum leap is a means that we now have to identify the core infarct from the potentially salvageable area, which will become part of the infarct if reperfusion is not established. In other words, what is called the ischemic penumbra. If reperfusion is not established, then that ultimately becomes the final size of the stroke. And with this new advanced imaging, we are now able to extend the time window with certain types of strokes. Now, wake-up strokes, I'll get to that, and late strokes. What if the patient, like the majority of patients who present late, they come in beyond that 6-hour time frame from onset of symptoms, which renders them previously unsuitable for mechanical thrombectomy or for intravenous thrombolysis. And the new type of advanced imaging has allowed us to shift from an analog clock deciding on a time that you can do the procedure to a tissue clock. Is there salvageable tissue or not? How much is irreversibly damaged? How much can be salvaged? And that is a quantum leap forward. So wake-up strokes are a little easy. Quite a number of strokes occur during sleep. We know that they tend to occur in the early hours of the morning. But according to our guidelines, it's symptom onset. And so symptom onset was when they're last known to be asymptomatic. So if you wake up with a stroke, if you went to bed at 7 o'clock at night the previous night, you've had 12 hours of sleep, it disqualifies you. Even though we know that your stroke probably happened an hour or two, if not less, before you woke up. But now they have done a study called the Wake-Up Study, in which they use simple MRI technology, diffusion-weighted imaging, versus FLAIR imaging. And if there's a lesion on the DWI sequence, and it is not yet on the FLAIR imaging, those patients were given intravenous TPA like they would be if you knew the time of onset. And they found that the results were exactly the same as that group where you knew the time of onset was less than 4.5 hours, with a 53% improvement to functional independence versus 42% with best medical therapy, with confident intervals and symptomatic intracranial hemorrhage exactly the same as when you knew the time of onset. So for wake-up strokes, this is a new option. It used to be a very frustrating position to be in, but now we have a new option. More important, with the advanced imaging. Now, advanced imaging, the most validated is rapid software. I'm sure there was others that will come to the fore, but rapid software was developed by Greg Albers and his group from Stanford University, and that is perfusion software. And it can be used on any machine, regardless of the manufacturer, and it has an algorithm for both CT and MRI. Now, what it does is it looks at the core lesion. So cerebral blood flow less than 30% is considered irreversibly damaged brain tissue. And then the Tmax greater than 6 seconds is delayed arrival of the contrast to tissue adjacent to that core lesion. This tissue is likely to progress to infarction, and now there's evidence to show that it does progress to infarction when you don't achieve reperfusion. And they create a mismatch map. So the one is red or the one is green, and you can see how big is your core lesion, and there's certain cutoff points that they've used, and how big is potentially salvageable. And if there's enough potentially salvageable, you can go and do a mechanical thrombectomy. That's what the trials did, and we'll get to those. And the same applies to using MRI if that's your preference, except with slightly different parameters. They use DWI sequencing, which is restricted water proton movement, which we quite been around for a while, and an apparent diffusion coefficient of a specific value, 620, to show the irreversibly damaged brain tissue. And again, the Tmax of greater than 6 seconds. And with the MRI, they create exactly the same thing, a mismatch map. What is salvageable? What is irreversibly damaged? And so what happened? They looked at patients who presented beyond the 6-hour time frame that all those other 5 trials were done in. So those patients came in between 6 and 16 and 6 and 24. And these are the 2 seminal studies, Diffuse 3 and Dawn. I haven't even quoted the reference. You just have to put them in Google, and a New England Journal just pops up straight away. Functional independence for severe stroke, meeting these criteria, in other words, salvageable tissue demonstrated using advanced imaging, 45% with mechanical thrombectomy versus 17% versus best medical therapy. Symptomatic intracranial hemorrhage, 7% mechanical thrombectomy, 4% with best medical therapy. 90-day mortality, 14% mechanical thrombectomy, 26% best medical therapy. The Dawn study, the one was done in the States, the one was global, 6 to 24 hours, again using functional advanced imaging to detect penumbra. Functional independence, 49% mechanical thrombectomy, 13% best medical therapy. Symptomatic intracranial hemorrhage, 6% versus 3%, and 90-day mortality, no difference. So phenomenal results. Numbers needed to treat after 6 hours of 1 in 4, that's pretty phenomenal. So my last slide. We've reached a new horizon with these rapid quantum leaps in stroke. We now know that time is crucial, but it's not all about time. It's how rapidly the infarct evolves, whether people are slow evolvers or fast evolvers. Fast evolvers, you probably won't be able to do terribly much, but fast evolvers are probably the minority. Slow evolvers are more common. And we now have the means in the future to be able to detect which patients are most likely to benefit from reperfusion therapies. Thank you very much.